Hello, everybody. Thank you all for joining in to another episode of Forecasting Success with me, your host, Ryan Brannan. I'm always happy to be here and happy to introduce you to special guests along the way for the great conversations that we have. And today I'm very excited to announce that I have Greg Gilbert with me. He's at Concentra, and we'll get into it from there. How are you doing, Greg?
Doing great. Good to see you.
Thanks for coming on.
Yeah, nice little backdrop here.
Yeah. That's not going to be a nice backdrop in a few months for me, but for now, it's not bad.
I understand. It's real, too. It's not fake.
It is real. It is real. And I think I'll spend most of the day in there instead of over here.
Yeah, gotcha.
Starting in January, but we'll get into that.
Sounds good.
So just before we get going into the issues, why don't you tell the viewers who you are, what you do, and a little bit about yourself.
The best part, right? You get to talk about yourself. Name's Greg Gilbert, as you heard. I have been with Concentra, which is an occupational health care provider, for over, 31 years. Man. And I'm over all of their reimbursement, government relations, contracting, credentialing process for all of our providers and clinical staff within the organization. So pretty big organization right now. I think we estimate we probably treat 1 in 5 work comp injuries nationally. See about 50,000 patients a day going through our over 500 centers. So we're busy. We're in 43 states, so we see a lot of different things in different states related to workers' compensation, and I get to have fun with all of that.
Yeah, and in Texas, not just workers' compensation, right? You guys also work with non-subscribers.
Absolutely, big part of our business.
There you go. So we just, for everybody watching, we've tried several times to get together to do this, and our schedules have just not lined up. So I'm very thankful that we were finally able to get this done. I think the first time we tried was at SACA when they were in San Antonio.
With iPhones.
Yeah. That's right.
And a big fly that was flying around my head the whole time. I think really happy we're redoing this because that was probably not a great look.
Yeah, no. And this is it's more a controlled environment where we're not going to be distracted by people walking around the conference.
Absolutely.
So thanks again for being here.
Great to be here.
Before we get into all that, of what you're doing, what's going on at Concentra and in Texas in particular, because that's what most of our viewers care about primarily is Texas.
Yep.
How did you get started with Concentra? Was that right out of college? Did you transition over?
Yeah, no, it's a good story. It's kind of odd. I actually studied and got my bachelor's of science in health professions at Texas State University, at the time called Southwest Texas State, probably one of its 10 different names over its history, and came back home to the Dallas area where I grew up and worked on my graduate degree, an MBA in health administration. I wanted to go into healthcare. That's what I wanted to do. And I did that full time for 2 semesters and realized I probably need to work in healthcare. And so I said, what am I going to do? And I found a job that was close by to where I lived in Las Colinas area. It was a nice little corporate job doing billing and collections for a hospital corporation.
Okay.
And that was $7 an hour in 1987.
Oh, you don't have to date yourself.
No, I know. I'm dating myself. I don't have a problem with that. You can tell the camera won't lie. So, and that's how I got into the industry. And so I worked my way up and doing different jobs in that, what I would call now the reimbursement environment, where you're billing and collecting for healthcare services. And I actually was moved down to Houston area and lived there for several years working for the same hospital company. They closed their office in Houston, fired everybody but 3 of us, and moved back to Dallas, right over there at Northwest Highway and Preston area. So moved back and I just stumbled upon an ad about a job for reimbursement for a small company called OccuSystems.
Okay.
When I first read that, I thought it was about an eye company. Sounded like that, right?
Right.
I knew really very little about occupational medicine, other than billing, work comp injuries usually coming through the ER. Mm-hmm. And so I went and interviewed for it. It was a very tiny company at the time, $25 million in revenue. So it was very small in 3 different states. And their focus was actually occupational medicine, primary care, physician, occupational medicine. It started, of all places, in Amarillo, Texas. Our founder started there, a physician. And his whole concept was really taking a focused approach on treating the injured worker and communicating with the employer, right?
Yeah.
Calling the employer after the injury and saying, Joe's hurt, he can do this, but he can't do this. How do we get him back to work as quickly as possible and productive, but at the same time, it might be limited duty. And that was a unique concept at that time. This was probably the early 80s or so. But the employers in Amarillo loved it. And they went to our founder, Dr. Reim, and said, can you open up a clinic in Dallas-Fort Worth area? And he said, sure, but I need some help. I'm, single doctor, entrepreneur, and I think he got with St. Paul Hospital. I'm not sure that's there anymore in Dallas.
I don't think so.
I don't think it is. And they went in a joint venture and opened up a couple clinics in Dallas, and that's where it started. So you went from one in Amarillo to 540 nationwide.
Yeah.
And so I came aboard in 1994, January of 94, doing what I just tell you I do now, mainly looking at the reimbursement, billing collection side of it. And been there ever since.
Wow.
Almost left once, but stayed. And I'll retire there, I'm sure.
Yeah. Hopefully not anytime soon.
Well, you never know.
We need that expertise that you have.
I'm a lot older than you.
With all those years of experience. And
they're trying to convince
knowledge.
me to stay longer, but we'll see.
Okay. All right. Well, put me in the convincing Greg to stay longer.
I got you.
I don't know who I'm going to go see Chicago Cubs games with next time we go to a conference in Chicago.
That's a great time. I can tell you, every time I see a game there, I think of that outing. Beautiful day and great baseball.
Yeah, and we had the perfect Chicago fans sitting right behind us.
Yes, we did. We learned a lot. We learned a lot about Chicago fans. That is for sure.
So, Chicago fans were long-suffering for everybody, but or for a long time. They were long-suffering, but then obviously they won the World Series, so times changed.
Yep.
So in the 30 years or so that you've been doing this type of work, what kind of changes have you seen since when you started up to today?
Gosh, that's a loaded question. So you heard I joined in '94. That was just shortly after Texas went through some pretty major reform. So there's still, I'm sure, some people around that remember those days. I believe it was 1979 session. No, excuse me, 1989 session, and then they implemented it in 91. Yep. And so I came shortly thereafter, and we've seen lots of things, lots of leaders, lots of different processes. What I really enjoyed watching is, in Texas being one of them, making changes. Sometimes they work, sometimes they don't, and learning from that and coming back and making adjustments and tweaks to the system. What also was unique and different, and still is to this day, is the fact that we had subscribers to the Act and non-subscribers to the Act. And that's hard to explain to anyone outside of Texas. They don't get it. And so that was a unique nuance compared to the other states we operated in that we saw and grow. And there was always question marks whether or not that would continue or not. And I think it's here to stay, personally. And so lots of different changes. And I spent a lot of time working on medical fee schedules in different states. I sit on several committees, and we've seen lots of changes with that, because right around that time, you may or may not remember, but that was when Medicare came out with their new fee schedule called RVRVS. And so I saw over the years go from one state, I think the first one was Pennsylvania, to now I think almost 34 states use some form or fashion of that Medicare-based fee schedule, including Texas.
Yeah. So, no, I really loved what you said too about the different states and how they do it differently. All right. So, when I worked for Governor Perry, we always looked at every state as in his words, or the office's words, a laboratory of innovation.
Yeah. And
so each state's going to do things a little bit differently, and you can pick up on those ideas and try and cherry pick the good ones, or find out which ones are going to work for your state. The legislature's the same way. Whenever we bring them a new idea, what states have this, what's going on in those states, and the Texas legislature, if California's doing it, we're going to do it the opposite way. If Florida's doing it, we'll probably try and do it the same way.
Gotcha.
That's not across the board, but it's a pretty good rule of thumb, particularly with California.
Yeah.
But the agency was the same way too. When I was commissioner, I'm sure it's still the same. Where we would go to these conferences, like that was a commissioners conference up in Chicago that I referenced, where you have the different commissioners talking about the issues that you're seeing in those states.
Yep.
And, particularly for the non-subscriber audience of this podcast, many of you probably remember that several years ago, there was legislation moving in a bunch of other states to implement what we had in Texas. And I had almost nonstop conversations with the commissioners and the different boards for those other states on how we make it work in Texas and how we didn't. Obviously, several years after that, it kind of took a back seat when the Oklahoma thing didn't work. And obviously, the Oklahoma thing was a lot different, but
it was.
I love that. And you have a similar perspective, I'm sure, with Concentra being in 43 different states, that you have to kind of navigate through all those regulatory issues, and just kind of the different cultural issues. You had said earlier that when you started, there was just the one up in Amarillo, and then you came on in 94. Now there's 430?
540 plus or so. It's still growing.
Yeah. Which is incredible.
Yeah.
And so when you're looking at issues from different perspectives and what different states are seeing, and then obviously also you have a technology component that wasn't there in 1994. I mean, just computers.
Yep.
We were able to try this on iPhones.
Yeah.
At one point, and then you come in here and look at all this technology.
Yeah.
So obviously everything kind of changes that way too, and I think kind of we were talking about this before the podcast, but I think it's a pretty good segue into it. We were talking about what the legislature is going to do.
Yeah.
And obviously in 2 months from now, maybe 3 months if I'm lucky, I'd count. I'm going to be living in there.
Yeah.
And the whole world of my world is going to be, what are these guys thinking? What ideas do they have? Because each one, they all, there's 181 of them in there, and they all come from different corners of the state, and they all end up in a same room essentially for 5 months. So they have to hash out these ideas. So it's like a microcosm of the laboratories of innovation.
Yeah.
But they're going to have a lot of issues on their plate. I mean, stuff outside of our ecosphere. Obviously, the electric grid is taking up a lot of air, but there are some issues that will affect our industry, and not just directly, not just claims management or billing or anything like that, but I mean AI, for example. I think you specifically mentioned that earlier. We've already had multiple interim hearings on AI and how to put some guardrails in place and what that looks like. I don't know if you guys are using any AI at Concentra, but I'd be curious to see what your thoughts are on it.
Well, you're right. Totally different than it was in 94. When I got there, we had no email and no internet. So everything was memos, inter-office mail. Yeah. AI, wow. So the last conference I was just at, about a month ago, or maybe less than that, that was the big topic among all the regulators, and that was IAIABC. So that was all states compared to SACA, which we've gone to a lot of.
Yeah, not to plug IABC, but I mentioned them twice, but that was the conference in Chicago.
Yeah,
we were both at. So
they both do great jobs. So AI was a big topic, and yes, we're into that, and certainly seeing a lot of bills related to guardrails around that. And I think I'm still learning a lot about it, Ryan, and some of it is probably beyond me to even describe different things. I mean, we talk about chat GBT and those type of things, and there's a name for that. I think it's generative AI, which most organizations are not really playing in that. They're doing things that make them more efficient and a better digester of large amounts of data. Right. And I think that's what you're seeing even in the property casualty or work comp area, as well as the provider area. And so we have really jumped into that and more on the what we would call predictive analytics side. As I mentioned earlier, we see a lot of patients. We have a lot of data, and it's healthcare data. Now, it's not the insurance company data, right? And theirs includes not only medical payments, but what also they're paying on legal cost as well as indemnity cost. You merge the two, it's great. But we've got all this medical data. And we've been doing outcome studies for years, so we know what it's like to pull data together and look at it, but it's tough. It's a lot of information, and you're pulling that out of your EHR, et cetera. So we have started moving into really clinical predictive analytics where we can look at these thousands of patients we've had over the last 5 years, 10 years, and predict based on what we're seeing in the data and how those cases ended up, where it might go if we don't take certain actions during the course of that treatment of that injured worker, all the way from psychosocial issues to whether they're off work or on work, restricted duty, et cetera. All those components are being looked at and processing through this language technology using AI to pull down and look at this information and be able to predict what might happen and help our clinicians go, hey, here's a red flag. If you see this happen based on past historical data, this might happen. You need to make sure you do these things. So almost prescriptive.
So not to put you on the spot, but if we could break it down for those that maybe don't understand AI or don't understand predictive analytics or even generative AI for that matter, could you break it down for me, like on a claim basis? Like, let's say you have an injured worker come in who I don't know, hurt their knee or something, but just whatever the example might be.
Yeah.
Like, how would that work?
I think it would come in and we would see these. Well, first off, we're doing two things. I really melded the two together. The other thing we're doing is using this data that we have to do chart audits to be able to go in, and that's what you're seeing a lot in medical care, looking to see how we documented where we had opportunities in terms of the documentation being better. Doctors struggle with that. Even with electronic health records, there are things that are missed that shouldn't be missed, and that information is really needed by claims processing to be able to understand what's really going on with the patient. So we're constantly looking at how we get better at documentation. So that's an important part. On the predictive analytics side, it's really down to clinical treatment. So they have a patient, Ryan comes in, he has a low back strain, but he has these comorbidities, let's say. Like me, let's say it's me, I'm overweight, I'm old.
I was just about to say, I was assuming we're talking about a different Ryan.
Me. Yeah. Let's just say me. I'm old, I'm overweight, I have 2 bad knees.
Okay.
And it probably contributed to the back strain that I had when I tried to pick something up at work. And so all these data points are then entered into the system, and based on prior visits over the last 10, 15 years that we've seen, when these benchmarks, and I'm not giving this justice, but when these benchmarks are met clinically, they're saying these are the things that can happen with that kind of case, with that person that's overweight, 2 bad knees, history of back issues, high blood pressure, and maybe a couple other medications that he's on. So all those things factor in, and they tell the clinician, here is what you need to look for in these situations with Greg Gilbert when he came in. And I'm simplifying it. I'm sure the people that maybe watch
that's
this
exactly what I was asking you.
But that's exactly what happens. And you're seeing that, and I just read an article today about it. It's not only happening on my side, the provider side, but you're seeing large TPAs, insurance companies in the work comp space starting to do the exact same thing. They want to be able to predict what might happen with that claim. Where is it going to go sideways and off the rails? And what can we do to intervene to guide that patient to better health quicker? So it's really stopping what may happen on the train wreck down here, because now you know that the track is busted here, and we can stop the train before it gets to the busted track. So
in theory, and maybe an application as well, I'm sure you guys are seeing some results from these efforts, but you're essentially getting the worker treated quicker at less risk for larger problems down the road, and then back to work and feeling better.
Yeah, when you're taking all this large language processing and putting it down and condensing it, you take a doctor that, your best knee doctor in Dallas that we'd all go to if we got hurt. He's got all these years of experiences up here, and that's great, but not all doctors have that, right? And so now you're taking all that data and giving it to all these clinicians. So you're able to provide better care and quicker, better, and get the injured worker back to work as possible.
Yeah, that's great.
It's pretty cool, actually. I saw some of it and I was like, wow. So I've seen a lot of things in comp, and you mentioned that earlier, that I think were kind of great leaps forward for medical care. This right there is something I've not seen in 31 years, other than the first time we sent electronic bills in workers' comp, because that was new back in, 98 when we first did it. Well, and that was big.
Yeah, it was. I mean, even just 10 years ago, telemedicine was a. In fact, you came. I was the commissioner. You came and did a presentation because a lot of the staff at the agency thought this was some newfangled, crazy concept. And, you know, what are we going to learn on a telephone? It's like, no, it's not. But even just that concept, 10 years ago was difficult for people to adapt to and understand. And obviously COVID slingshotted that.
Yep.
But yeah, so I mean, and those are incremental steps.
Yep.
This is an express lane.
Yep. This will be really cool to see. I think maybe you and I get back together over drinks in 3 years to see where it went. I'm excited about it. But this again is totally different than doing generative, where you're saying I want to get a presentation on this topic and it spits out something that's got a little bit of bias in it sometimes, and this is just more just pumping out data. Somebody said, can you have bias in these predictive models? You might, because you might say, well, my bias is, as a clinician, I think this is what we think is the good model of treatment, like a treatment guideline, and that's your bias. And so you're comparing to something of what is good, what does good look like, and you're trying to move to that. So you have to be careful with that. It was a big topic at ARAWC. So you know all those things are being considered. It'll be fascinating to see in 3 years where we stand.
So since you just got back from that conference and these topics are being discussed, what are some of the guardrails or concerns that people had with the technology?
Well, you know, what I keep hearing from regulators, and this will be in Texas or anywhere else, the first question is they want to know what's being done. I remember there was a regulator from one state said, it's a black box, and I want to know what's in that black box so I know what you're doing with my injured workers.
Okay.
You know, and I know it sounded interesting, but they said, tell me what's happening here. Because obviously you get a little jaded as a regulator because you see all the bad stuff too, right?
It's a triage unit for sure.
Yeah. So you worry that maybe it might be used for nefarious purposes or to deny claims or do things like that. And I'm not seeing that. But I think just the lack of understanding what may be happening and how they're using it is scaring some people. And all that needs is just some transparency to it. And once they've done that, I think everybody goes, oh, okay, I got that. That's okay. That makes sense. And people were very clear at this conference and others that I've gone to about where the gaps are. Like I said, bias is one of them in terms of how you set up the model, and being clear and transparent of what you're doing. Privacy is a big deal. It's a concern. You've got to watch that carefully. So that's kind of what we're seeing related to how the states are looking at it. But there is some concern. And then I've got one state, Colorado's a great example. That's, you know, we get this when we do an IME or a designated doctor exam. The biggest issue they have is the mass of medical records they get on a case that's, let's say, gone on for years, right? And you've got to weed through all of that, you know, paper,
right,
and bring it down to something that's understandable, and that's tough. We're starting to see companies that are taking that data, putting it through a very similar model that we're doing, where it's I'm going to use the wrong term, but machine learning, language machine learning, and condensing all of that information down into a readable overall book of information related to that case. And Colorado is using that because they actually ingest that and are going to do it themselves and then hand it to the doctor reviewer. So
are they building that system now?
They're using the company that built the system. Who had already built it but didn't think about it from that use.
Right.
And then somebody said, well, this would be great to take all this mountains of data. That's the biggest issue I hear with IMEs in multiple states, including Texas, is how do you digest that information and pull out the relevant information you need and really kind of get rid of all the duplicates, because there's a lot of duplicates in that stuff, or stuff that doesn't make sense. And also weed through any potential, issues that it may be in terms of bias of how the information was sent to you.
Yeah.
So that's pretty cool that you're seeing state agencies doing that, and they've talked about that at least the last two conferences. They're about to roll that out.
Is that Paul getting up there?
Mm-hmm.
Yeah. Paul. Right. Paul's an ideas guy. He's got some good ideas.
I was pretty excited about that.
Yeah, I like that too. And that also goes back to the whole laboratories of innovation concept, right? I mean, if they can figure that out and that goes right, and they have a model that's built, you may see some legislation in Texas or other states on if the agencies don't already have that ability. Of course, with non-subscribers, you wouldn't need to go through the government hoopla.
Yep, but they may still be doing reviews, right?
That's right.
And so that would be kind of cool to see. and a tool that doctors can use to, and not only in comp, but you can look at that in group health too. I mean, I'm sure there's a lot of that goes on with disability ratings and things that, that are not related to comp. So
yeah. Well, I just meant in terms of the non-sub guys wouldn't have to go through a regulatory hoop to get there.
Good point.
It saves them.
We love that part. Yeah. I don't know if you know that when we were acquired in 2015, Select Medical bought us, and they're non-subscribers. So we've been non-subscribers since 2015, and just recently we were spun off, and we're a wholly owned public company now.
Okay. See, I just said what's going on these days.
That was fun, but we I guess it was June. I should know this date exactly in my mind. Went public. Select Medical decided to spin us off. We were, I think, a great partner with them, but I think they felt like the story could be told better between the two organizations. We were happy and excited about that. We really loved our time with them. Great. Good leadership there, and so we went public in June, and that was quite an experience. I got to go up there and go to Wall Street.
You ready to ring the bell?
Ring the bell. Did that whole thing. It was. They do it right there. They know what they're doing, and they've done it a few times. Yeah. So we enjoyed ourselves. It was a good time, and now the serious business starts when you're standalone. You can't hide behind your parent company if things go wrong, and so that's going to be interesting. And of course, a couple of years to decouple from them on shared services and things like that. But so it's been an interesting ride with them. And again, I'm right in the middle of the non-subscriber part of business. So, and we treat, as I mentioned earlier, a ton of non-subscriber patients in Texas. And somebody's always asked me, what's the difference between treating that and a subscriber patient? And it can get a little challenging, but we find our non-sub clients are really open to doing good things and allowing the doctor to practice medicine, but holding us accountable, right? And we kind of sometimes closely follow things that go on in work comp and sometimes not. So you'll have a little bit of flexibility that's there with the non-subscriber you don't get with the subscriber.
Right.
And so for us, we're fairly agnostic to it all. Our treatment model is going to be pretty much the same. We may have one non-subscriber client that says we want you to do this with physical therapy, and another client says we want you to do this. So you have to be able to move on those requests. But for us, and I get that question a lot when I go outside the state, what's that like? And we said, we're really kind of fine with it.
Yeah.
We still treat them the same exact way. And so I think it works.
Yeah.
It works.
That's great. I love that you used physical therapy as as an example there. I'm not sure how many of ARAWC viewers know, but I represent the Texas Physical Therapy Association at the Capitol. And speaking of working together, the lobbyist that works for the PTs with me is Steve Coble, who also lobbies for Greg at Concentra. And, so that's kind of just wanted you guys to know where the reference was coming from.
Well, yeah, we do a lot of physical therapy.
We have
a lot of PT
therapy.
Patients, and Select Medical, before they spun us off, was the largest PT company in the nation. So we were kind of enmeshed in that business, and lots goes going on with PT as well. So
and there may be some issues in the Capitol regarding PTs this next session. I know that they were working on expanding their ability to treat without referring physician first. They're also working on copay legislation. The nurses are looking to expand their scope of practice to the full limit of their license, which they've not been able to do in Texas for years and years and years. And they didn't even get a hearing on that last legislative session. I mean, that went nowhere. Not even a courtesy hearing in late April just to say that we did it. But this most recent, 2 weeks ago, they had a hearing on the Senate committee, and several of the former no votes on that committee had clearly flipped in favor. So I think you're going to see some scope issues come back.
Scope's always fun, right? I've been told that's probably the one thing that a lot of legislators run from because it's so contentious.
It is.
But you got me on one of the big topics that I've been speaking about for the last year in different states, and Texas is not excluded from that, and that is simply the matter of physician access. And comp is a very physician-focused niche in the healthcare business. Employers want their patients to see doctors. They don't want them to see mid-levels. PAs and nurse practitioners. But the mere fact of it, and the data shows from the AMA that there's an access issue. There aren't graduating enough physicians. There's not enough of them out there to treat. And practically, I don't know about you, but when I go see, and I have an issue, I want to go see my primary care doctor, I rarely see my primary care doctor.
Yeah.
If I want to go in and see him quickly, I'm going to see my nurse practitioner. I think and I've said this in other states, and I'll say it in Texas, we have a lot of regulations, a lot of things that we want treating doctors to do, and including exams that we really don't want a mid-level to do.
Yeah.
Practically, what we're seeing now in multiple states is that because of that, we're getting delays in treatment in terms of doing that final exam or that final IR or MMI because mid-levels aren't allowed to do that.
Yeah.
And so the discussion we had in Georgia on a panel on this topic was, how do we open up our minds and thought process with the new world and the lack of access and our unique system in workers' compensation, where we really want the injured workers to get to see a doctor when I go down and see a nurse practitioner for almost everything else on my group health side. How do we balance those two? And is it up to the regulators or even on the non-subscriber side for the employers and others to start looking at that going, we want to relax that a bit and recognize the practicality of when this is good and when maybe for sure we don't want to see a mid-level practitioner. But we're seeing more and more scope expansion in that level, virtually because of the access issue with physicians.
Yeah. And I think, and that's a very real issue. And I think a lot of people are approaching it differently on how to go about resolving it. And while you were talking, I remembered when I was commissioner, I went to go to a Cisco facility in Houston. Big truckers, huge warehouses, different rooms that were different temperatures to store different foods. I mean, just quite an operation. And throughout their facilities, they had little nursing bays, essentially, where if you got hurt, you go and you see the on-site nurse or mid-level practitioner. And then they had access to a telemedicine to a doc. And so if it was above their ability to properly, I don't want to say treat, because that's a big buzzword at the Capitol, who can treat or diagnose, but the ability to recognize what was going on and have and to resolve the issue, then you could do the telemedicine right there. If that didn't work, then you take the injured worker off, but otherwise they could just go right back to work that same day at that same time. I thought that was one interesting approach. Obviously, not every employer is large enough to be able to have those kinds of facilities on site. But you're right. I mean, we've been talking about lack of doctors and access to care for years. I mean, that was the impetus behind the tort reform movement back in the mid-2000s. To put limits on the damage caps because doctors were fleeing the state. And I don't know if they've come back. I don't know if we have enough.
Well, I think I saw DWC reports showed doctor participation. It's gone down slightly. I would argue that, which is true, and I don't think they're too concerned about that. But we have an increase in population as well. Right. So I think it will continue. I think I've seen the DWC and I've seen others take really good steps related to opening that up. They just did something related to allowing for a telemedicine doctor to discharge a patient who had no impairment and no, in a very specific language. We needed that during COVID because all these, they had to see a doctor and they couldn't do a telemedicine visit that way. It had to be face-to-face. So that was a great step forward. I think we're starting to see some out-of-the-box thinking from both regulators and employers on when it comes to telemedicine. And the next big thing on telemedicine that we're seeing is behavioral health. That's becoming really, really big because, number one, there's a real access issue with that. And there's a compact law that's out there that's allowing behavioral health clinicians to be able to treat over multiple state lines without being licensed in that state, which is not normally the case with telemedicine. So you're seeing a lot of work being done on that. We just started doing some telemedicine behavioral health, and it's gone over like gangbusters. Oh, good. Yeah. And so I think you'll see more and more of that in the comp world because we're seeing more and more presumption laws. We're seeing more and more PTSD laws that are coming through. And so and we recognize we have a behavioral health issue in this country. And so we've got to be able to fill that gap too. And that's hard. And by the way, telemedicine is a perfect venue for that, for behavioral health. Most people don't want to go and lay on a couch, right? Or they don't want to go to the office. They don't want the stigma of that. We're finding the satisfaction of being able to do behavioral health over telemedicine is fantastic. So that's pretty cool to watch too.
That's neat. Is that able to be done in Texas now?
Yeah.
Oh, great. So that's not going to come up while we're in there.
I don't think it will, but I have seen you're going to have a lot of, I think, behavioral health bills coming through. So
yeah,
we're going to be watching that to make sure that it's going to be allowing more. And we're seeing in other states, I'm not sure we're going to get that here in Texas, where they're going to even lower levels of clinicians to broaden the ability for people to access behavioral health. Instead of just a psychiatrist or psychologist. I think they're going down to social workers and other things. That's California. I don't think we're going to see that here yet. But
maybe in Austin.
But they recognize there is an access issue.
Yeah.
Yeah.
Okay. Well, that's good to know. And then, as you mentioned, presumptions. There's always presumptions bills. I think we'll see some presumption bills coming up.
Yeah.
Settlements is likely going to come back around. I'm trying to think what else in the crystal ball. Does Steve see anything?
Yeah, we talked about, we saw something that looks like there's going to be some discussion on access.
Yeah.
There'll be a broader.
There'll be a lot. It'll be
Not
a
just
broader. No, 100%. It'll be in the context of broader, and then
underserved areas as well.
It'll be one of those things where it's like, does the comp world want to come along for the ride or not?
We'll see.
Yeah, sometimes they do, and sometimes they don't.
You know, what we're finding is they typically don't
Yep.
Until they really have to.
Yeah.
But it's fascinating to see these discussions go on, not only here in Texas, but in other states where people are starting to recognize, I see what's happening in my personal life when I want to get treatment. I recognize that us putting these barriers in place may drag out a case much longer than we want because they can't see a doctor, especially in rural areas, for 2 or 3 weeks, right? And you're paying 2 or 3 weeks of potentially indemnity pay. Nobody wants to do that if they don't have to.
Yeah.
So I think we're going to see some things like that.
Yeah, and the rural discussion is ongoing as well, and it's a separate component, but a great example. As to the issue overall I think in fact they tried to do. They did pass a bill, and this is another kind of side part of the issue, just looking at it from a different angle. There's veterinarians out there, which obviously is outside of, we don't do much of that in comp. The veterinarians, there's none in the rural areas, and you need them out there. That's where all the animals are.
Right.
And so they passed a bill that created a program to put a financial incentive into getting more veterinarians out there. Because they didn't want to lower the standard of care beyond. So the veterinarians, their association was adamant that it was a financial need, and that was the problem. So they passed a bill that essentially said, if you go out in these rural areas as a vet and you do it for X number of years, you get money from the state, a pretty significant amount of money.
Helps pay off your student loans.
Right? Yeah, exactly right. And so then last session, they found out that no veterinarians had moved out there.
Yep.
And what was the response from the veterinarians? It's because there's not enough money. So we need to have more money to expand the program.
Yeah. And
so there's pushback, which I don't think was there before on these types of battles, amongst the conservative side, saying, look, you told us that the solution was to continue the high level of care from the most trained person, and that it was just a financial issue. And now we've ballooning these government programs. So the veterinarian is just one example. There's all these programs that are now ballooning up over this.
Right.
And nothing's changing. Right. Yeah. So at some point that bubble is going to have to pop.
Yeah, there's a little experiment there that went wrong, right?
That's right. Exactly.
And they really got to dig into, that's the same thing with, like you said, rural healthcare. You've got to figure out why they're not going. I mean, we have some clinics where we have a hard time recruiting doctors. They just don't want to be in that city.
Yeah.
And so it's real. And, whether you're an animal or you're an injured worker in the system, you're going to run into these challenges, I think, more and more as we see medical schools not graduating enough doctors.
Yeah, that's right.
And they don't want to go into primary care medicine. They all want to go and be a specialist, right?
Yeah, that's right.
So your first line of defense is hard to get.
100% correct.
Yeah.
So, I think you're going to see a lot of discussions on that going forward. What other issues do you see popping up?
Well, one of the things I've talked a lot about is pre-authorization. I think Texas did some really good things several years ago where they looked at their pre-authorization list and really said, what are we doing here? And are we doing too much? And should we really bring it down to the areas that really make sense to do pre-authorization? And they did that and never looked back. I don't think they had any issues with that. And so we're seeing that. And one of the big things you see pre-auth in different states, and including here in Texas, is physical therapy. Years ago, we had some real abuse on physical therapy and chiropractic medicine, and they put some controls into place saying, I think after 6 visits, you need to get it authorized. And so I think that was prudent at the time. And I like that approach because I think after 6 visits, a therapist should be able to go, I'm seeing functional improvement or I'm not.
Right.
And if you are, then you can easily make the case, I need more visits. I rarely see a carrier come back and say, or an employer or anyone come back and say, no more PT if you're seeing functional improvement. They're reasonable about that. But at the same time, we have some states that will look at authorization, or even some folks that will come in. If you're a network, you could do that in Texas, say, I want my first visit of physical therapy authorized for you. Do any treatment at all. And that blows up what the physical therapists you represent consider the sports medicine approach. When, our Cowboys quarterback or whoever gets hurt, they don't wait to get pre-authorized and get treatment. They get treatment right then. And that's how we've always treated our injured workers as in essence, injured athletes. And the quicker you get treatment, there's data out there everywhere. Any physical therapist can show you, all the studies have been done, that the quicker you get treatment, the quicker you get better. Yeah. And there's a psychosocial approach to that as well.
Yep.
You've been to therapy, you know what that's like, getting hands-on and getting worked on. You really feel like you're getting taken care of, and that's important in the comp world, frankly. So there's been several good studies that have shown that, requiring pre-authorization before the first visit, it really slows everything down and increases overall case costs, both medical care and indemnity, and slows the recovery. So you're seeing more and more of this on the national side, and with the same arguments on Medicare Advantage, where the government's looking at that and saying, you guys are really doing way too much pre-authorization and it's harming your population. So there's some, I think, new rules coming out, or have actually already come out for Medicare Advantage saying, you got to get rid of a lot of this because Medicare doesn't do hardly any pre-authorization.
Right.
So we got to take a lesson from that in the comp world and go, when does it make sense to do it? When does it not? Let's get early interventions. Let's get them treated. Let's get them seen. If they're making improvement, functional improvement, great. If they're not, then you need to stop and look at what the next treatment plan should be. So that's right in the wheelhouse of any good therapist, and let them treat, let them see what they can do, and then go from there.
Yeah, and those are all excellent points. That is a bloody fight at the Capitol.
Yes, it is.
So it is guaranteed to come back. A couple sessions ago, the legislature essentially allowed the pre-auth to kind of balloon.
Yeah.
And I think they're not seeing the result. And they got another example of trying something and it not working.
Yep.
I think they're trying to peel some of that back because they initially had done essentially gold cards, like for docs. If you played ball enough, then you didn't have to go through that process.
Yeah.
But nobody's getting gold carded.
Yeah.
So that was just a hearing that we just had.
Interesting. I saw a couple states do that kind of bill. Maybe you're talking about it. I don't remember seeing that in Texas, but they were saying basically that, and I think that's maybe what you were saying, if a doctor, and this is what we see a lot when we do pre-auth in these cases. So, for example, in states where I have to pre-auth PT at first visit, 99% of the time, it's yes. So I've spent money calling. Insurance companies spent money, or the company they hire to do that spent money to get the same outcome 99% of the time, which is yes. And so I saw a couple of bills, and this may be what you're talking about. I'm not sure why I missed that they said if a provider, doesn't mean a physical therapist, any provider goes through an authorization process, and 95% of the time, then the percentage changed in the bill. Let's say 95% of the time in the last 12 months, you authorized treatment for him. We're not going to let him, for the next 12 months, we're going to let him go without any pre-auth. And you go back and look at it and see how it worked. Yep. Is that the same thing?
Yeah, that's essentially the
Did it
concept.
not work?
I mean, I'm sure it depends on who you ask, but
Gotcha.
I can assure you that the providers do not think that it works.
Yeah.
And I mean, I heard that when I was at the agency too, right? You hear all these horror stories about needing approval to do something, and the person who was approving it was out of town for 72 hours or whatever the case may be.
Yeah.
So you're always trying to tweak around the edges, but at some point the whole thing needs to be looked at. And so it'll be interesting, and I'm sure they'll look at what other states are doing, what's working, what's not working.
Haven't seen much of that. That's just been out there.
Yeah.
Haven't seen a bill passed on it yet.
Okay.
I like that idea. If the data's accurate, and everybody agrees to the data that I'm getting approved 95% of the time, why the heck not? As a doctor, would I not want to go into that program and go for the next year without having to pick up the phone and pre-op?
Absolutely.
You've trusted me. It's like the concept with certified networks. Theoretically, you're going to get the doctors in that network that you want. You're going to manage them. You're going to monitor them. If they're not doing good work, get them out of the network, right? That's the concept. Right. And I think I just saw a report card come out for network doctors, and it was pretty darn favorable for in-network.
Yeah, I believe it.
Yeah.
I believe it. I did not look at the network report card. Haven't had to look at that in a few years, so I feel pretty good about that.
I bet you do.
Anyway, there's going to be a lot that happens between now and when they adjourn sine die at the end of May.
Yep.
We've got the election. We have a speaker's race in the House. We have this new faction of Republicans.
Yep.
So it's truly a three-party system inside the House.
Makes it hard for people like you.
It does.
Yeah.
I'm not going to lie to you about that. It definitely does. Unless you're playing defense, and then it makes it really easy.
I got you.
So it kind of just depends on what's going on. And there's a bunch of factors that go in there, but it's with the lieutenant governor and the speaker at odds, that doesn't make it very easy either. But there's honestly we have. And I know I said 2-3 months. It's October now.
Yeah.
Back in there in January, so 2 months. Soon it'll be here before we know it. But at the same time, that is an eternity in politics. Yeah. It really is. So plenty of time for all that stuff to get.
Next 30 days will be fun. So
next 30 days will be very interesting.
Yeah.
I have outside of obviously the presidential national politics, I have. There's probably another 10 close races.
Yeah.
Probably maybe 6 of which could flip from R to D, and if they flip D, then that's going to give Phelan a boost.
Mm-hmm.
So I've got several friends in those races.
Yeah.
So I'll be out on the road most likely helping them out.
Good.
But then that'll die down, and then it'll be just a mad scramble to June.
Always fun.
So you mentioned having a few beers afterwards.
Yeah.
Maybe in June we get together. We look at all of our predictions for what they were going to look at.
I love that.
How it's going to go.
I love that.
We'll see. We'll check the boxes and see how it just.
Well, I'll see you in mid-November too. So
that's right. I'll see you before.
Yeah, we can talk about it then too.
Okay.
Well, we can't talk about the session, but we can talk about nationals. So.
That's true. That'll be fun.
It's been great.
All right. Well, thank you for coming. Appreciate it.
Always fun talking to you, Ryan.
Yeah, and always great to have you guys here with us. Thank you very much for tuning in. Always good to catch up with Greg, and if you get the chance to, I highly recommend it. Not only is he extremely knowledgeable in our world, but has a lot of great stories. He's a sports fan. As we mentioned, baseball. He went to Texas State. Their football team's having a good year. He's also rooting for my ponies this year.
Oh, I love the ponies.
So a lot of stuff to talk about if you get a chance. In the meantime, though, we'll let you go. Thanks again to ARAWC for being our title sponsor. And we will see you next time on another episode of Forecasting Success.